Yeah.
Oh.
Where you? Tell me a little bit about your story. Where are you from?
We're live. We're live now. I'll tell
Yeah.
you after the show. We just went live a second ago. All right. Ladies and gentlemen, we are back with another live stream hosted by Alpha News, orchestrated by the First Tuesday Conservative Group. Today, we are joined by Dr. Scott Jensen, a state senator and medical doctor who's made some serious waves in Minnesota and nationally with his commentary about the coronavirus. In addition to providing insightful and, I would argue, accurate commentary on the coronavirus situation, Dr. Jensen has also faced some issues, some political issues, and faced some pretty staunch opposition to what he's been saying. We're going to discuss all that and more tonight. Dr. Jensen, thanks for being on with us.
Thank you so much for having me, and thanks for this important discourse, because with what's going on, none of us can afford to ignore Teddy Roosevelt's comments when he talked about being in the arena and being willing to get bruised and bloodied, because if we don't, then we fall into the trap of Edmund Burke when he said, all that it takes for evil to prevail is for good men to do nothing.
Absolutely. And, people that are our leaders should be more in the arena than anybody else. I think that's why a lot of people have appreciated your message. I suppose just take it from the beginning here for some of our viewers who might not know your entire story arc. You started months ago vocally opposing the way Minnesota is handling the coronavirus. Tell us about that.
Well, March 17th was the day that we went into the lockdown. And March 6th was the first case in Minnesota. I believe the first death from COVID-19 was February 29th. So in the middle of March, I think all of us wanted to do our part. We were confused. It was fluid. This was new territory. So when Governor Walz said, we're going to have to lock things down, we took a deep breath and we said, okay. But a couple of weeks passed, and as we learned what Governor Walz had done, we started asking questions. How do you make a determination between what's an essential and a non-essential business? Mm-hmm. If we arbitrarily say that a business is not essential, but at the same time, that business is very safe. Perhaps it's a landscaper who works alone. And perhaps the landscaper is particularly skilled at helping homeowners deal with end of winter ice thaws and trying to make certain that water isn't leaking into the basement or blowing out a tie wall. Non-essential? Safe? So I authored with Senator Jim Abler and Senator John Huffman, a Republican and a Democrat, a commentary in the paper. I think it was like March 31st. 3 days later, I received an email from the Department of Health. And I was flying through my emails because I receive a lot of them. And I was just about to delete it, but I noticed something about vital statistics. And I thought, okay, well, this could be about death certificates. And because I've been practicing medicine 35 years and I do a fair amount of death certificates, I thought, well, I better just check what this is. And so I opened up the document and I'm skimming through it. And honestly, my heart sank. I thought, well, this isn't right, darn it. And toward the bottom of this communication was advice that felt very much like I was being coached, that in this new era of COVID-19, we should be particularly interested in utilizing COVID-19 as the underlying cause of death. And I thought, well, I've never received any kind of coaching like this before. And the document even said, if COVID-19 is a contributing condition, you can consider using it as a cause of death. Well, contributing conditions clearly have a separately marked area on a death certificate, part 2, if you will, where this can go. And what was really alarming was it said, if something else is a contributing condition, go ahead and park it in section 2. But if it's COVID, then don't put it in section 2, put it in section 1. And I thought, well, this is nuts. And then there was a link to the CDC. So I went to the link and there's a 7-page document and they talked about how COVID-19 was a pandemic, yada, yada. And then they gave 3 scenarios where physicians might learn how to consider COVID-19. And it was the last scenario that troubled me the most. It was an elderly woman who'd had a severe stroke and was wheelchair bound. and had suffered for 2 or 3 years and had made a determination that she did not want to be, if you will, resuscitated or the receiver or the recipient of heroic efforts.
Mhm.
Well, anyway, they gave a little vignette and said that this patient developed a high temperature and a severe cough. Well, that's not typically the way COVID-19 presents, by the way. High temperature in the elderly, no. Severe cough, oftentimes the COVID-19 cough is more, if you will, insidious. So the history didn't quite add up. But then it went on to say that she developed pneumonia, declined going to the doctor, and died. But they found out that she'd been exposed to her son, who was later found out to have COVID-19. And so this would be a COVID-19 death. And that was enough for me. I said, all right. So we had no laboratory confirmation. We had no test ordered, no test done. We don't even have any notion that anybody thought about doing a test. And we're going to put this down as the COVID-19. I would think that the initiating event in the train of morbid sequential problems this person encountered would have started with a stroke. And that stroke would have led to powerful weakness. And as she maybe became slowly dehydrated, she became weaker and she experienced some level of renal failure. And then she may well have aspirated some of her own phlegm and her own bacteria. And that caused what's called an aspiration pneumonia, and it went on to take her life. We have no COVID-19 test on her. To me, this just smacked of wrong. So a few days later, I was asked if I would go on a Fargo Moorhead news program to talk about the commentary that we'd put in the paper about non-essential and essential and safe and not safe. And during the course of that discussion, Chris Berg asked me something, and I said, well, Chris, honestly, I don't think Minnesotans really want things sugar-coated or sort of prepped. They would like it straight up. They want their information so that they can review it. I think Abe Lincoln said, tell the people the truth and the nation will be in good hands. Anyway, something to that effect. So I said to Chris, I said, honestly, this reminds me of the communication I got from the Department of Health the other day, when the Department of Health told me that I don't need to be precise or specific. I can go ahead and use COVID-19 as a cause of death if I presume that it was the case, or I assume, or I think it's reasonable, or more likely than not, but clearly moving away from precision. And Chris Berg interrupted me and said, hold it. He said, you mean that in the last few days you got some sort of a document from the Department of Health that was telling you how to do it? And I said, well, yeah. And that was where, for me personally, the world pivoted. Because I think the next night I was on Laura Ingram's show with Fox News. And then during that discussion with Laura, I made the comment that if someone were hit by a bus and they're taken to the emergency room and we find that they have 2 collapsed lungs and some initial preliminary labs were done, and over the first hour and a half, the patient succumbs and dies, and the lab tests come back showing that, oh, by the way, there was a positive COVID-19, we certainly wouldn't put COVID-19 on the death certificate. It was a bus accident. And this flew in the face of what Deborah Birx was saying on the White House COVID team, where she said nobody dies with it, everybody dies of it, which is ridiculous. And so when they asked Dr. Fauci during a press conference about some things that had come up from my conversation with Laura Ingram, Fauci said that I was just a distraction. So that was where things are at.
So you've spoken out against these death certificate practices. You've obviously said that if someone clearly died of pneumonia or old age or of a stroke, that you're not going to label them as a COVID-19 fatality. What percentage of physicians do you think are on the same page as you? And when we're looking at these death certificates, how much can we trust the accuracy given this guidance?
Great question. I think the number of physicians that are with me on this is not enough. I think it should be much more. I'm not saying that the CDC is bad or the Minnesota Department of Health is incompetent or anything like that. I'm simply saying, hey, I've been taught to be a thoughtful, skeptical thinker. I don't just swallow the bait. I'm not a big fan of groupthink. So please don't demonize me because I've said something that flies in the face of your own personal view. Let's talk. And I reached out to hundreds of physicians around the state of Minnesota asking them, this is what I said. This is what I did. Am I wrong? And they said, absolutely not. The physicians that got on my case the most seemed to be people that felt like I was being too contrarian, but they weren't telling me what it was I said or what I shouldn't have said. I mean, I learned in March that I would be attacked by bureaucrats. And I was, because I remember bureaucrats contacting me in March saying that I wasn't a good soldier. I should be more go along, get along with Governor Walz's program. And I couldn't do that. So the bureaucrats jumped me in March. And in April, it was politicians. And in May, it was the mainstream media. New York Times did an article on me on a Sunday above the fold, and they took cheap shots at me. And then in June, it was when the Board of Medical Practice said that you're under investigation. Honestly, Kyle, I could never dreamt that something like this would happen. I mean, 4 years ago, I had one of the biggest honors in my life when the Minnesota Academy of Family Physicians chose me as the Family Physician of the Year for the state of Minnesota. And 4 years later, I'm having my license investigated because I'm a skeptic.
Yeah. And to add to that, I think you make a very good point that the opposition to you doesn't really articulate specifically what you said, only that you have contradicted the mainstream narrative. It seems to be, from my perspective at least, more an exercise in compliance than an actual issue with your message. But you brought up kind of the next thing I want to talk about, which is your license is being investigated. Tell the viewers about that.
So I spent 40 hours preparing a response. It was a 5,000 word, 8-page document that explained that I'm not providing reckless advice and I'm not spreading misinformation. I had 70 pages of attachments. I pointed out that if what I had said regarding the Department of Health and the CDC had been so erroneous, then why did a week later the Department of Health come out with a clarifying communication? And why did a month later they come out with another document clarifying things along with a video? Why did the CDC come out with another document clarifying that we needed to make certain that we were being precise, specific, and looking at the initiating event in the sequence of causation in regards to leading to death? So I also pointed out that Pennsylvania had to pull almost 200 death counts from their COVID-19 tally because the coroner said enough is enough. These are not COVID-19 deaths. Colorado, same story. Kentucky, same story. New York, opposite story. What did Governor Cuomo and Mayor de Blasio do? They said, we have 3,700 deaths that are more than the typical amount we'd expect in this time frame, and they are not specifically identified. They must have been COVID-19. So we saw New York jump from 7,000 to 10,700 overnight. Then within weeks, we saw US congressmen from New Jersey and New York complaining that the dollars being allocated from the CARES dollars were not being distributed correctly because they shouldn't be distributed based on 2019 distribution of Medicare dollars. They should be distributed more to the states that got hit the hardest. Sounds like they're concerned more about themselves. They didn't care that the hospital in Alexandria, Minnesota had to do everything that the hospital in New York had to do. They had to stop doing elective procedures. They all of a sudden didn't have a problem with a surge or with being overwhelmed. Their problem was that their hospital was a ghost town. Nobody was there. All of a sudden they were bleeding money at a rate they'd never bled before. No pun intended.
Yeah, that's something we saw with Mayo Clinic as well, a drastic drop in procedures, and it threatens the hospital's ability to continue to function. So now we have a pandemic, and we also have hospitals that are not financially viable anymore. It's kind of insane.
Because what also happens is now we have nurses that are furloughed. So what are nurses going to do? Well, they are going to have to make alternative plans in terms of their child care. So you don't get to reverse the actions that came from your decisions. You can't all of a sudden flip a switch and have all the nurses back where they belong in the hospital. You basically, as Ayn Rand might have said in Atlas Shrugged, you've cranked this engine down to nothing and you don't get to turn a switch and get it back going.
Yeah, you can't simply delegate which part of the economy is going to run today and then not run tomorrow. I mean, it's like a freight train, not a go-kart. You can't stop and go on a dime. So when it comes to this investigation of your license, where are we at with that process? I'm aware that the first complaint was dismissed. Now there seems to be some second round of scrutiny. Are you afraid that they might pull your ability to practice medicine?
Anytime the Minnesota Board of Medical Practice sends you a letter stamped in big red letters, confidential, you'd be a fool to sort of take that lightly. And so I'm doing that. I've prepared a thoughtful response, I think, and I've sent it back to them, and I've sent to the Board of Medical Practice the videos that I made on July 20th and 21st, which are the dates involved. I put on social media the letter I received from the Board of Medical Practice because I think it's critically important that this entire process be transparent. These complaints are not about the quality or nature of care I'm giving to my patients. These complaints are political complaints. These complaints say I'm a danger to public health. This is politically motivated. So now I'm in that limbo area where I'm hopeful that sometime within the next month, I'll be notified that the board has done its due diligence and has dismissed the allegations once again. But until that happens, you can't help it wonder what could they do. And certainly they could limit my practice. They could say, this is not going to be something we'll allow you to do. And that would be problematic for me on multiple levels.
Mm-hmm. I like that you highlight that the complaints aren't about the quality of care you're giving to your patients. The complaints are about what you're saying in the public sphere, which is part of your other job as a state senator. I don't understand it.
Well, this is a unique situation for the Board of Medical Practice to be in as well. They know that their mission and their organization is being weaponized to get at me and try to get me to shut up. And at the same time, they know that they're dealing with someone who is the vice chair of the Health and Human Services Committee, and I'm actually supposed to speak up, and I'm actually supposed to have opinions, and I'm actually supposed to have an appetite for intellectual curiosity so that I can say something to people. Mm-hmm. So this can't be any fun for them either.
Yeah, of course. I have to ask you, we've had all the public debate about the shutdowns and the masks. Moving beyond that, what is the conversation looking like in the medical community? Because we can have all these debates about should you wear a mask to the grocery store or not, but when it comes time to write peer-reviewed papers and to do professional data analysis, where's the medical community at with assessing the virus?
And that's a great question. And it also, it hints at something deeply disturbing, and that's my profession. We're being fractured. We're being fractured by ourselves. We know full well, virtually every doctor I know realizes that randomized control trials, double-blinded studies, and peer review, those are the things that get us where we need to go. Science is at its very basic level, three things. It's observing, measuring, and then hypothesizing. And when you have a hypothesis, you have to create an experiment to see if you're right or you're wrong. And if you're right, then you have an obligation to give this to someone else so that they can do a similar study or experiment to confirm or deny. These are the steps we have to go through. Well, we've been doing that for 25 years and more in regards to viruses, and virology, and infectious disease, and masks. And what do masks accomplish when we wear them in surgery? And what do N95 masks accomplish when we try to put them into a level 4 or level 5 laboratory? And what do they accomplish for the industrial applications that they might use? But quite honestly, in the last 4 or 5 months, without the benefit of adequate peer review, and the New England Journal of Medicine just came out and said something to that effect just a few weeks ago. It's either that or JAMA. But one of them came out and said, we are not being given the opportunity to conduct the kind of peer review that we should demand of ourselves because of the sandwiched, crunched time frame in which we're working. So we've seen 25 years of good data, good studies thrown out the window because we're panicking. And we're seeing science literally harpooned so that fear and frenzy can take over. So really, the medical profession's at a bad place. When I went into med school, I remember grand rounds. Grand rounds was a highly intoxicating time of intellectual curiosity, and people would say, that's the wrong diagnosis, we need to do this, or that's the right diagnosis and we need to do this. Grand rounds was tremendously stimulating intellectually, and that's how we got answers. Tumor rounds, I would go to tumor conferences and we would see a patient presentation. This person with colon cancer has stage 4 disease. This is our option. We could do this or we could do this. And we would argue about it. We didn't gather together to have a kumbaya moment. We were scientists trying to find the best answer we could. We're not doing that now. We're acting like a bunch of politicians. You put a mic in front of us and we're tearing down our colleague without ever having talked with him or her. So we're in a bad spot.
That's something that I've noticed in the mainstream media as well. If you turn on certain outlets or listen to certain publications, they present doctors in the medical community as sort of this monolithic pro-mask, pro-shutdown group of people. You seem to suggest that that's not always the case.
There's a guy named Dr. Scott Atlas out of Stanford. I don't know him. I've never met him, but he works with another doctor, John Ioannidis. These are very bright, highly acclaimed, highly awarded physicians, and they are absolutely getting torn into by other physicians. People are writing letters back and forth. I mean, Scott Atlas is a bright guy, and he's not a member who's going to just jump into groupthink. He's been appointed now to the White House COVID-19 task force. He's not going to knuckle. He's not going to knuckle to the president or to Deborah Birx or to Dr. Fauci. This is a very smart guy who spent his life using his head. And we're seeing him besmirched because someone disagrees with him. I'm not saying he's all right. I know that I'm sure not all right. There are days I wake up in the morning and I have an opinion, and by nighttime I've changed it.
Well, any healthy academic or healthy skeptic will change their opinions from time to time when the evidence dictates that you should do such. When it comes time to analyzing the effectiveness of the public response here in Minnesota, what kind of assessment would you give? Have we done a good job at slowing the virus? And these recent changes we see in the numbers, is that attributable to Governor Walz's mandates?
Let's just do a report card.
Sure.
Governor Walz, I think that first 3-4 weeks, I think he gets a solid B+.
Sure.
Legislature, the only divided legislature in the land, trying to work together, we maybe get a B.
Mm-hmm.
But after you skip over the first month, I would give the bureaucrats a D. I'd give the legislature, between the House and the Senate, not playing partisan games, I would give us maybe a D+. I would give Governor Walz a D, because he has surrounded himself by people that I don't think are challenging him enough. He should ask for the models that he's used. He should ask for independent thinkers to come in. And I'm not saying me, I'm not that smart. There's other people way smarter. But he should be asking for an audit. He should be saying, why have we been so far off? Why did I come out and say to the public, we're going to have 74,000 deaths? Then I changed it to 29,000 deaths. And then I said that we'd have almost 1,000 deaths per day in July. And none of that ever happened. We have to critically think. I know the job of being governor at a time like this has got to be tough. But frankly, we should not get good grades. And Minnesotans should not be that happy with our performance. We're doing a terrible thing to our children. And we're going to find out someday that the kids were not at risk from COVID-19. The kids have been at risk from the decisions of the politicians and the bureaucrats.
Yeah.
We're creating a host of adverse childhood experiences and inflicting them on 4, 5, 6, 7, 8, 9, and 10-year-olds. We're telling them to wear a mask. We're telling kids to learn how to read and pronounce letters watching someone with a mask on. This is lunacy.
Yeah, absolutely. When it comes to that discourse within the legislature and the legislature's relationship to Governor Walz, what climate are you sensing? Are people trending further apart? Are people trending closer to maybe an end to all the shutdowns? What's that conversation look like?
we've gone from a minor fracture, perhaps, to a full-blown compound fracture where one of the bones is stuck right through the thigh. Now, this isn't healthy. This isn't healthy at all. We've got the leaders in the House and the Senate fighting. We've got tactics of retaliation being used. We've got the governor insisting that this is moment-to-moment decision-making and he's got to retain all of his emergency powers. We've got the Senate saying we're not going to confirm these people. I mean, we've got a bonding bill that's been pretty close to being done that doesn't seem to be able to move forward. We're seeing splintering, fracturing, demonizing one another. I don't know how it could be much worse.
Do you think that in November, when the elections hit, that might be sort of the necessary catalyst for change to push things forward? Because you identified there's a fracture, and it seems like we've reached a point of stalemate. Would new politicians help in your analysis?
I think once the elections are over, I think people will be willing to take a breath, maybe press the pause button. I think the leaders in the Senate and the House and the governor will all realize that, okay, we now have the players elected that will be, if you will, present for the next 2 years. We've got to create a budget in some pretty adverse circumstances. I think that there will be a coming together and saying, okay, let's work together. I'd like to see us not wait until after the election, but I'm not optimistic.
Yeah,
I honestly think that one of the biggest problems we have in Minnesota is that we need more citizen legislators. We need more people coming from all walks of life. We need people to come down, do their level best to solve problems, to listen to one another, to remember Stephen Covey's book in the late 1980s, 7 Habits of Effective People, and seek first to understand, then be understood. Maybe we should listen first and then talk.
Absolutely. I think that'd be a well-heeded message at all levels of any democracy, by and for the people. That seems to be forgotten these days. So when it comes to the coronavirus statistics that we've been seeing, we've always got that the numerator and the denominator. You've got the numbers of people that have the virus, the numbers of tests that are being thrown out, and I've had this burning question the entire time. Does testing sort of artificially inflate the lethality of the virus? Is there a chance that basically everyone's had it at some point or another, and that by testing people, you're only increasing the numbers of positive results and making the statistics look more scary? Or is that just sort of a conservative talking point that I've, maybe repeated too many times?
That might be a conservative talking point that needs a little breath of fresh air.
Sure.
Let's look at it. When we were first doing the testing, we knew that we were getting a skewed sample because the people that were getting tested were symptomatic. And we weren't even testing all the symptomatic people. We were testing only the worst of the worst in terms of symptoms, fevers, cough, shortness of breath. And we're also trying to test healthcare workers. We weren't spending a great deal of attention focusing on people in long-term care facilities, and we're paying the price. So we were told the initial case fatality rates came out and said, oh, the percentage of fatality is 5%. But then we had Department of Health people saying, well, but hold it. For every positive case we have, we can assume that there's somewhere between 10 and 100 more that haven't been tested and diagnosed. So that would take the 5% fatality rate down. If it was 10 times, it would bring it down to 0.5. If it was 100 times, it'd bring it down to 0.05, which is half what many flu epidemics are.
Yeah.
But the Department of Health people didn't want to talk about that too much because that would be minimizing things. So what we saw was this tension. We knew that our testing was skewed, but we knew that for every person that we tested positive, there was another bunch. In Clara County, I think they've had 50 for everyone. Another study had 85 for everyone. So we were probably undercounting cases at that point in time, but we just didn't know by how much. But deaths are fairly easy to count. And there was trust then because we thought that when we were given a COVID-19 death, that it was indeed fact and not, if you will, massaged. So initially we could say, well, we can figure this out. We know how many deaths, we know the numerator and the denominator rate the fatality count was being undercounted.
Mhm.
And that was in part because of some of the discussion in New York. I think you can make an argument either way. It was overcounted or undercounted. If you've got someone who's dead on the scene of an accident and is put down as a COVID-19 diagnosis because he tested positive, and Deborah Burke says nobody dies with it, they die of it, then that's an overcount. But if there's people that die and we weren't certain and we didn't have the testing capabilities, could they have been missed? Yes, they could have been missed. So I think when we look at this, I think we have to sort of step back and say, okay, we are in a state of absolute mass confusion now. The PCR testing isn't as reliable as we'd like it to be because we're running so many cycles to get the positive test. It would sort of be like doing a hearing test on someone, trying to find out at what decibel level will you hear the tone I'm giving you. And if we have to, we won't stop at 20 decibels, which is normal hearing. We'll go to 30, 40, 50, 67. And if we get to 120, which is standing next to a Boeing 747 taking off, and you say, yes, I hear that tone, we got what we wanted. This is sort of what we're seeing happening with the cycling with the PCR test. So we've absolutely bastardized that data. So we don't know what to do with tests anymore, but we still know one statistic. If we would be honorable and precise, we can figure out who's dying from COVID-19. And if we look at that, and if we look at anybody's data right now, COVID-19 death, that fatality rate is dropping. It's dropping significantly. I don't care if you look at New York City, Italy, Minnesota, it's dropping. If you look at Sweden, it's plummeting. The fact of the matter is, it seems like this virus in the first 3-4 months did exactly what it wanted to do. And that was confuse us, mystify us, and it went after the vulnerable. And in this situation, the vulnerable were those that were living in long-term care facilities. It probably, if you will, was hardest on the people most fragile. And so a lot of those folks died. They died alone because of some of our policies. But now we're getting better. We're getting a broader understanding. We're talking about mini blood clots, cytokine storms, low flow oxygen, budesonide, dexamethasone, hydroxychloroquine, remdesivir. We're getting smarter. And with it, we're getting better. And we're learning from hospitals, and we're learning from the patients that have been in the ICUs. So from my way of thinking, it's going to be hard for us to look with confidence at the, if you will, case rate. We've got some places counting cases based on positive tests, but sometimes 3 tests were done on the same person, were all positive, and they're counting it as 3 cases. That's not 3 cases, that's 1 person, 1 unique individual. So we've botched it so badly when it comes to that. But we should be able to count fatalities. And I think we should be able to let physicians and patients decide together how they would like to approach it if they got it. I had a patient call me this afternoon. He just had his serology test come back positive. So he's had COVID-19, if the test is reliable. Why did he have it done? Because about a month ago, he had a couple days where he had a little headache, felt tired, had some diarrhea. And for that reason, he tested. Now, those are not top tier symptoms. Top tier symptoms are cough, shortness of breath, and fever. But he had it, and now he's immune. There are so many thousands and thousands of people that have had this disease that don't realize it.
Yeah. Yeah. If the virus is that benign for some people, of course, it's devastating in vulnerable communities. But if it's that benign for some people, then do you even think it's fair to label it a pandemic, or do you think that's more of a scare tactic?
Well, I think a pandemic is pretty much a standard that, if you look at World Health Organization structure, it's a stratified decision-making process. And so when you get to a certain level, it's a pandemic, and I think it is. And they've also got the same ability to step it down as things get better. I was a little bit surprised that Governor Walz said the other day that he would release his executive peacetime powers when Mayo Clinic said that the COVID-19 was no longer a threat. Mm-hmm. He said something like that, I think, on NPR. Mm-hmm. And I don't know why that would be the metric that we would look at. I think that we have asked that question. What metrics should we look at? And I think we should be able to be clear about that. Mm-hmm. And I think if the governors in the various states want to talk about that or confer with the White House or confer with CDC or World Health Organization, but I don't know why we should make that a mysterious thing. I think people should be able to know that. I mean, we have to quit treating thoughtful, engaged citizens like they don't get it. Because I'll tell you, politicians, bureaucrats, and all the rest of you, people get it. They're paying attention.
Absolutely, you're right. It seems like there's a barrage of criticism heaped on anybody that wants to engage with this issue publicly or maybe question alternative hypotheses. It doesn't seem very productive to me. So one thing I'm left wondering is if we have trouble ascertaining accurate statistics and testing may not be accurate, the way governments work with that data might not be accurate, then what metrics should we be using when we deal with this thing? And as a legislator, what sort of data are you even left with to make informed decisions?
Well, for me, the case fatality rate, the number of COVID-19 deaths is huge.
Sure.
When I watch the laboratory confirmed case count go up, that doesn't strike fear in my heart, because I don't know if we'll ever get the vaccine that we hope for. And it may well be that we're gonna have to go it without a vaccine. We're gonna keep trying. But our track record isn't that terrific in regards to single-stranded RNA respiratory viruses vaccines. It just isn't. I mean, look at our influenza vaccine programs. I mean, many years our influenza vaccines have been 10, 20% effective, if that. And so we really have to be careful about being overconfident just because we've got big pharma, plowing forward. I mean, this is the lottery they're going after. But for me, I look at the COVID-19 deaths. I look at how many beds, especially in Minnesota, I look at how many beds are in the ICU are being used for COVID-19 patients. I did a TV program earlier today in the Netherlands. And just before I came on with you, Kyle, I was doing one with Australia. Yesterday, I was reviewing the data from Russia and from Belgium. And I know last week, some of the things I had to say were playing out in Pakistan and India. So I've really tried to pay attention. And I know that there's people way smarter than me out there. But I think when I look at the whole world as best I can, we're all sort of in the same situation. We're desperately trying to find what are the important pieces of information we should follow. I'd like to think that we could all maybe take a chill pill and not be quite so mean-spirited to one another. I think we could have conversations, but I think we should look at the laboratory confirmed case, the new cases. We should look at the deaths. We should look at the ratio. I think that we should pay attention to testing. Testing could be the cat's meow in terms of getting kids back in school and if we can do PCR testing and have it back in less than an hour, that would really allow us to potentially hit some focal points. If we could find out that if you do a PCR test and it's positive in the first 5 or 10 cycles, that person might be more one of these big spreaders, and that person we really need to say, hey, you need to quarantine for 14 days or whatever. But if we're getting positive tests at the 20th or 30th cycle, that these people may well not be very likely to transmit at all. And then also, I think one of the metrics, it's not really a metric, is what about personal responsibility?
Yeah.
What if we said, let's all, anybody who's got a BMI greater than 30, let's all go out on a crash diet and lose 5 pounds. And let's all go ahead and start some supplemental zinc, vitamin C, vitamin D. Let's all do a little bit more meditating, so maybe our minds could be more at peace. Let's all be slightly friendlier, because it seems like we're healthier when we're not miserable and bitter. What if we could do those things? How might that help us pivot in this thing? And it would give us a certain level of confidence. But instead, it's Chicken Little. The sky is falling. And the sensationalistic media coverage, just read the headlines. They're terrible. I mean, they're doing everything they can to ramp up the fear. We've got a whole big section of people in this country who think that this pandemic is going to slow down dramatically on November 4th. Well, that's almost the height of cynicism. And that cynicism was given birth by the way the bureaucrats, politicians, physicians, and the media have been dealing with this. We created this problem. This is not something you can blame on the citizens of Minnesota or America. This is just who I said it was. Bureaucrats, politicians, academics, mainstream media. This is where it's come from. We've done everything we can to scare people silly. And we've got people paralyzed into thinking that this is some sort of existential threat to humankind. It's not.
Well, that's a wonderful message of optimism. We like to have those on the show. And a quick note to our viewers, if you have any questions or comments you'd like us to address as we come to the end of our time here, please type those in chat. We love responding to viewer questions. One of the last questions I have for you, Doctor, is about the so-called coronavirus season. People keep saying that, this is going to be a recurring thing like flu season. And as we come into wintertime again, we need to brace for some sort of second wave. What are your thoughts on that?
Well, on that question, I would probably be inclined to refer to Dr. Mike Osterholm. He had quite a good article about how this might play out. And he, I think, had 3 or 4 different scenarios. And he talked about, if you will, your initial wave, and then maybe some sort of a seasonal drop off to be followed by a second wave. And then there's the initial wave, and then more of a sine wave like this, where we get these little blips upwards, but not really a clearly defined first wave, second wave kind of thing. And then he had another couple models in there. I don't have the expertise to know. I think that we have to remain fluid. I'm thrilled at how so many of the frontline doctors have done everything they can to glean information and to learn from this. The doctors in New York City that, we're really getting hammered. The doctors in Italy trying to pass on the information so that the profession of medicine could come together and try to figure out what can we do. It's troubled me deeply that at times we've sort of created a binary choice. If you have COVID-19, you either get better on your own or you get worse and go in the hospital. And what I'm hearing from so many people is they want that other choice. If they have the disease, they're not getting better as quickly as they thought or hoped that they might, that they could do more with home therapies. And that's why we have to have the discussion about steroids like budesonide and dexamethasone, hydroxychloroquine, remdesivir, oseltamivir. We have to discuss these possibilities, low flow oxygen, vaccines. We got to run the gamut. But I think that the idea of telling people that they don't get to participate in their treatment plans is problematic on many levels. And that's where I come down real strongly on. Patients have the right, we've passed legislation called the right to try, but then we have this pandemic and we've told patients, oh no, you don't get to try this and you don't get to try that and you don't get to try that. Oh, forget that legislation that's called the right to try. We weren't talking about this kind of situation.
And now if we have viewers out there that might be diagnosed with COVID-19 and they, want to know about their options and they want to have some resources that they could look into so they kind of understand how to advocate for themselves, what would you recommend? Where should people get reliable information on what these different therapies might be and, sort of the reality of the virus?
Well, clearly the internet has many good sources of information, but I would call your doctor and make an appointment. You go in and have a 10 or 15-minute appointment with your doctor. And if your doctor's not interested in hearing your thoughts or your concerns, then I'd find another doctor, because this idea that doctors are supposed to be the kingpins is wrong. Patients will get the best care when they are willing to be their own best champion. Patients are able to do it. They should be empowered and encouraged to do it by doctors. We should be saying that if there's a professional golfer in the room and there's a caddy in the room, Tiger Woods is the patient. The caddy is the doctor. I carry the golf clubs. I tell the patient that there's a sand trap on the right and there's a water hazard beyond the green. And I hand the patient the 7-iron and they got to hit the ball on the green. And that's the way it should be.
Yeah, I think that's an excellent metaphor and something that a lot of people don't always understand. Really quickly, we want to refer to this question from a viewer here. Barb Katz asks, is it true that medical facilities were being monetarily reimbursed for COVID diagnosed deaths? Good question.
It is a good question. And I think I need to clean up the language on that. There is a financial incentive for hospitals to have COVID-19 be one of the discharge diagnoses in the Medicare population.
Interesting.
CMS came out, and if you have a person in the hospital on Medicare, whereby the hospital is getting paid on what's called a prospective payment schedule, that's where, regardless of whether the patient's in a hospital for 2 days or 5 days, the hospital gets a lump sum of money. If it's garden variety pneumonia, it's typically about $5,000, give or take. But if it's a COVID-19 respiratory illness that you put down for a discharge diagnosis, then it goes to $13,000. And if during the hospitalization, a ventilator is required, then it's $39,000. Now, USA Today went after me on this. They called me and we had a lengthy interview, and then they went and fact checked it. And they checked it with experts all around the country. And when they came in with their decision, they said, these facts are true. And they said, Jensen's right. What he's saying is right. And it wasn't me fabricating this. I just got on the phone and called hospital administrators. And I looked it up on Medicare's basic, information on the web. So yeah, there is this. But in terms of a death certificate, I think people are getting confused. The death certificate itself has nothing to do with payment. What we're talking about is when a patient leaves the hospital, whether it's because they're discharged home or to a long-term care facility, or they're dead. In any of those situations, there's always a discharge diagnosis, and usually there's main diagnosis and then other diagnoses.
Absolutely. Very, very nice answer. We have another viewer question here. Why can't we go back to normal and let the chips fall where they may? People are smart. No masks, no social distancing. What are your thoughts?
Well, some people have called that picking off the scale, if you will. Mm-hmm. And I understand. I think we should move in that direction. I think we should have kids in school. I don't think we should do any more lockdowns. I think the masks should be far more curtailed. And I think the masks should be focused on protecting the vulnerable. I don't think that I would just try to say, okay, we're going back to normal. I would say, let's identify vulnerable people. Let's identify those kinds of situations where we know super spreading can take place. Should we be doing closely gathered hundreds of thousands of people in one place? I'd probably lean into the expertise of infectious disease and epidemiology folks. But whatever decision we make in regards to masses of people coming together, I don't think we should discriminate against churches or funerals and then say, oh, by the way, if you want to riot or demonstrate on a bridge and pack in 1,000 people and not wear masks, that's okay. No, that's not okay. Yeah. We need to be fair and decent and reasonable, and that's not being. I mean, some of the landmark things that happen in our lives are when loved ones are suffering or dying. Mm-hmm. And we don't get to just turn it on and turn it off. When we deny ourselves and our families the ability to appropriately say goodbye, that can lead to mental health problems for years. Absolutely. So we've got to stop thinking that our world should focus entirely on COVID-19. We should be thinking about people committing suicide and people that are anxious and domestic abuse on the rise and child abuse not being reported and all the other things. Because if you look at all the other things, honestly, combined, they may not show up on a dashboard, but they're far, far bigger than this doggone COVID-19, for which we seem to be willing to paralyze our society, our economy, and then on top of it all, be meaner than the devil to one another. I don't get it.
That's something I've observed, in every social group and community I'm a part of, is people are despairing, and it's not boding well for a lot of members of the community. We've got just 2 more viewer questions. The first one's pretty simple, so I'm just going to ask them together. The first question is basically, is the information about the case against you from the board public information? Like, are those records publicly accessible? And the second question is, are you aware of a study done by the US military on flu shots, which posits that people who got the flu shot are 36% more likely to also contract coronavirus?
2 questions. The first one's a little easier. My initial investigation of the Board of Medical Practice, that information has all been put out there. I have put the letter of dismissal of the allegations, the 70 pages of attachments, and also the 5,000-word, 8-page response. In regards to the active investigation, I have posted the letter I received from the Board of Medical Practice, and the videos in question on July 20th and 21st are a matter of public record on social media. I have not posted my correspondence to the Board of Medical Practice because they've not made their decision yet. I will post it once they make their decision. The Board of Medical Practice is obliged to keep this private. I am not. That has been checked. I did not want to violate any rules, But since I'm the accused and I'm not allowed to know my accusers, I do have the ability to be transparent about it. I chose to do that for several reasons, but perhaps the biggest one was I think this is a worldwide engagement that should take place. It should be transparent, but especially I do not want, if you will, media to be able to frame it or somehow come after me. So I said, I'm just going to be totally open about it. I'm not going to let this be some deep, dark secret, some burden of shame. I'm not doing that. Second question was in regards to people in the military receiving influenza vaccines, and could this put them at greater risk for contracting COVID-19? I am aware of that study. I think that we don't really have conclusions that we can really take to the bank, if you will. But I'm also aware of studies where the possibility of an MMR booster shot for some might help their immune system respond better and could provide a measure of protection for COVID-19. And I've wondered in my own mind, I've wondered for many months. I remember sitting next to Senator Julie Rosen, and we were talking or mumbling, Health and Human Services Committee meeting. And I said, it strikes me as really interesting that the children and the population between 0 and 25 have been so impervious to this. They just haven't been touched by it. And I was wondering, is it because of their more recent immunization history? Because in that first 5 years of life, and then even thereafter for the next 10 years, they're getting more vaccinations. Would this play a role? I don't know. I just don't know. I do know that regardless of what we do going forward, I'm passionate about the fact that people need to understand that a vaccination isn't like getting a shot of penicillin for strep throat. A vaccination is a medical intervention whereby we do something hoping for a result, but not certain whether it'll happen. It's sort of like chemotherapy for cancer. We're hoping that we get a kill rate from the chemotherapy agent so that the patient can survive the cancer. Well, with a vaccination, we're hoping that whatever we're injecting into that body, or sniffing in the nose if it happens to be a nasal vaccination, we're hoping that it'll elicit a certain kind of response from the immune system. So it's not like taking a blood pressure pill and lowering blood pressure. It's a very complex interaction between our immune system and the vaccination itself.
Absolutely. Makes sense to me. Dr. Jensen, thank you so much for being on with us tonight. I think we had a wonderful conversation about a nuanced and important topic. I think just my note to the viewers, we should all take heed of what Dr. Jensen has told us and participate in an informed, educated conversation about this, and try to stay positive. It's a very difficult time for a lot of people, and I know we discussed kind of the element of despair associated with this. I think it's important that we all try to keep our spirits up and take some of those steps that the doctor recommended, like supplemental vitamins or meditation, to keep your head up during this difficult time.
And Kyle, if I could just add one closing comment, I would say this. If we really think carefully about what kinds of things we might be about in terms of our nature, our each of us, what choices do we make? Who are we? Who are we as people? A lot of times we do things because it's transactional.
Yeah.
We do this, so we get this. But if we truly say we're going to be kind and we're going to be courageous, those are two responses we can have to this that really aren't transactional. If I tell you I'm going to be courageous about this, it doesn't get me anything other than a challenged medical license. And if I tell you I'm going to be kind, I can be kind, but you don't have to do anything for me. You don't have to pay me $1. You don't have to be kind back. So if we could all just say, if we could just focus on being kind and courageous, I think it would help us, because the infighting, the bickering physicians, the divided country, the fractured political party system, this isn't going to help solve the problem. It's really not.
No, not at all. I think an excellent, thoughtful note to leave the show on. Everybody tune in September the 22nd, a Tuesday, for another interview we're going to have with Sarah A. Carter. You may know her from Fox News and the Sarah Carter Show. We're very excited to have her on in just a couple of days. Also, keep watching your emails. As you well know, we're now scheduling interviews not just on Tuesdays, but on all sorts of days of the week as we draw closer to the election. And as always, keep watching Alpha News at alphanewsmn.com, and keep watching the Alpha News Facebook page and Twitter as well. I also recommend that you follow Dr. Jensen across all social media platforms. I very much enjoy doing so. Ladies and gentlemen, thank you for joining us tonight, and we'll see you again next time.
Thank you, Kyle.
Yeah, are we still up? Are we still live, Scott? I think Scott left. I think we're still live. I see it. Hold up. Let me leave and I'll call you back in a second.